So welcome to the LGMD Diagnosis and Clinical Care Plenary Session. My name is Laura Rufabach, and I'm the co-president of the Jane Foundation, whose mission is focused specifically on dysferlinopathy, which also goes by the name LGMD 2B, R2, or Myoshi. I'm really excited about this session as I know that getting a definitive diagnosis and consistent, informed care can be challenging. The three talks during this session will discuss what the challenges are, and what can and is being done to improve diagnostic timelines and care management for the LGMDs. So in your programs, the first talk was supposed to be given by Dr. Karsten Bonneman at the NIH. Unfortunately, he wasn't able to come today, but he has sent two of his colleagues to give the presentation. The first part of the talk will be given by Sandra Donkervoort. She's a genetic counselor, and she manages the NIH Neuromuscular Gene Discovery Program, which is led by Dr. Bonneman. The second part of the talk will be given by Dr. Payam Mohassel. He is currently the Associate Professor of Neurology at Johns Hopkins, but he was formerly with the NIH and Dr. Bonneman's group. And they will be discussing the NIH Diagnostic Program for Neuromuscular Disease and how it's used to identify new disease genes and to aid in diagnosis, as well as the identification of anti-HMGCR as an LGMD mimic. Sandra?
Thank you so much for the invitation to come here and speak today. So I'm the genetic counselor that works with Dr. Karsten Bonneman at the NIH in the Undiagnosed Neuromuscular Disease Program. So recently, the genetic testing capabilities has rapidly evolved in neuromuscular diseases and in the limb-girdle muscular dystrophies. And the ability to do multi-gene panels as well as sequencing large amount of data through exome or genome sequences has had great impact on the genetic diagnostic capabilities within our clinics. And this also allows us to learn more about the underlying clinical spectrum that's associated with the specific genetic subtype. So the advances in genetic testing can lead to a rapid diagnosis and significantly shortening the diagnostic odyssey that many of our patients has faced over time. In addition, it also reduces the costs that historically came with doing one single gene testing at the time. And then specifically within the neuromuscular field, there are some very large genes, such as Titin, RYR1, and Nebulin, that with this new technology are very readily testable. However, it comes with many challenges, and those will be addressed in this session as well by my colleagues. But because we're generating so much genetic data, it comes with a very large number of these variants of uncertain significance that come back on every single test report when we order genetic testing. That can lead to diagnostic uncertainty, it can lead sometimes to misdiagnosis, but also to wrongly assigned diagnoses. And then even when we see patients at the NIH who've had extensive research-based genetic sequencing or exome sequencing or even genome sequencing these days, approximately half of these patients remain undiagnosed, and additional work is needed. So therefore, it's very important to have an iterative research-based study that allows us to really put all the puzzle pieces together for every single patient and obtain a genetic diagnosis. So in some recent work that we did, we were able to see that some of the more recent mutational mechanisms are related to hidden or deep intronic variants that were not being picked up by the more traditional methods. And we've been able to pursue more research-based testing to get to a diagnosis. So this is an example of how our program is set up at the NIH, which is really in Bethesda, Maryland, just like a metro right away from where we are. So we see patients in our clinic for a very extensive phenotype or a clinical characterization visit. So everything that we do starts with the patient. We try to learn as much as we can about the underlying disease manifestation, which includes extensive neuromuscular examination, but also imaging study, both muscle MRI if possible, as well as muscle ultrasound. Further workup at any of the tissue, either bank biopsy tissue or fibroblast study, and then future research-based genetic testing that can include our exome, genome, and RNA sequencing. Recently, this was applied to a series of patients that we saw that all came in with progressive muscle weakness, hyperlaxity, as well as contractures and respiratory involvement, with the clinical diagnosis very characteristics of collagen 6 myopathy and dystrophy. Both the clinical presentation as well as the imaging finding and the findings in the muscle histology were very consistent with this diagnosis. However, more traditional-based collagen 6 testing in the clinic had been negative. By pursuing genome sequencing in addition to RNA sequencing, looking at the muscle readout in patient banked biopsy tissue, we were able to identify a recurring variant that was deeply electronic, hidden within the collagen 6 gene. And by further work in our lab, we were able to show that this, in fact, is a disease-causing variant. And by working together with many of our collaborators, many who are in the room, both internationally and nationally, we're able to now establish that this variant is one of the most common single causes of collagen 6-related dystrophy and providing us with new avenues for therapeutic targeting and intervention. So moving on, leaning into some of the work that Dr. Mohassel did, is very recently we worked on a novel gene. It's the HMDCR gene. It's part of this very complicated pathway. That's a new pathway that was only recently established to be part of causing a muscle dystrophy phenotype. We've known about this pathway for a while in the more anti-HMDCR myopathy setting that Dr. Mohassel will address. But very recently, us, together with collaborators, found that disease-causing variants in this gene causes a novel limb-girdle muscular dystrophy, and in one patient, there was a clinical treatment response to oral methylonolactone. At the NIH, we were fortunate enough to see 3 patients from 2 families for the genetic discovery as well as the clinical characterization. So they were patients were seen at the NIH. They were all undiagnosed locally, but they came to us, and they underwent the deep phenotyping, including ultrasound, muscle MRI imaging, and an optional muscle biopsy. Here are the 2 families. In brief, family 1 is 2 affected siblings with a very early onset progressive muscle disease that was severe and progressive over time in both a boy and a girl, 2 siblings. In family 2 is the patient is a now 39-year-old female who first started to note weakness at age 10 years, and it was progressive over time with loss of ambulation and requiring non-invasive ventilation at age 30 years. So we were able to pursue research-based testing and in both families, found 2 very rare variants associated with HMDCR, which is a gene that at that time had not been associated with disease before. And by putting the data together and doing further clinical characterization to learn more about this novel limb-girdle muscular dystrophy, we pursued muscle imaging just to see how this gene impacts a patient, and we were able to do muscle MRI in our older patient. We were able to see that in the upper thighs, there was more we call fatty infiltration, so more involvement compared to in the lower leg. Muscle histology was also consistent with the limb-girdle with the dystrophic process. And then taking this together with our coworkers who independently had identified patients as well with HMDCR-related dystrophy, we're starting to learn more about this novel limb-girdle muscular dystrophy and really seeing the spectrum that's associated with this new condition. And this is, of course, only the start. We're hoping that by additional patients being identified, we're starting to learn more and more about the overall clinical and genetic spectrum. So taken together, we feel that recessive variants in HMDCR are a new cause for limb-girdle muscular dystrophy. And this is exciting because it also implicates this new cholesterol pathway as an underlying cause in muscle dystrophy, in addition to some other recent gene candidates that we're working up in this pathway. And we hope that by understanding this pathway, that it also provides us with new therapeutic avenues and targets that can be developed within the lab. So taken together, it's very important that with all this collective genetic technology that we bring it back to the patients, but also starting off by really understanding the underlying symptoms and phenotype for every individual patient that comes into our clinic. And we rely on, with the gene discovery work, we rely on our international and collaborative approach, specifically for those patients in whom extensive testing has been unrevealing. And of course, getting a genetic diagnosis is the gold standard. As we all know, it's essential for management, prognosis, recurrence risk, genetic counseling, as well as to identify potential trial-based therapeutic interventions. So with that, I want to thank my team, specifically Dr. Bonneman, everyone that worked on the HMDCR project, and of course, all the families and patients for participating. And then with that, thank you. Here's part two.
All right, so this is part two of the same talk, and I'm going to talk a little bit about some of my experience when I was at the NIH with seeing the patients in the diagnostic program that Sandra was talking about, but it actually ended up being not a genetic disease, but it originally was mimicking limb-girdle muscular dystrophy. I do want to briefly mention the history of the term LGMD, which really originated in Newcastle with Sir Walton and Nattrass, where they really described this disease and the criteria for it really in distinction to facioscapulohumeral muscular dystrophy, which had a different name at the time, Duchenne muscular dystrophy, and congenital muscle disease. And really, from their description and over the years, there are certain elements that sort of stand out for this disease, is that it's of non-congenital onset, it is proximally predominant in its presentation, and it typically spares the facial muscles and extraocular muscles, and it has to have a dystrophic muscle biopsy, and elevated CK was kind of added on later on as a criteria in clinical evaluation, but it was implied early on from the original description that it needs to have a genetic etiology. But as physicians were seeing patients and evaluating them with LGMD, it became clear that this is not a homogeneous disease group, and not all the patients who present with limb-girdle weakness actually have genetic muscle disease. So there are certain clinical features that a clinician may pay attention to. calf hypertrophy is an example here that you may see in certain subtypes of limb-girdle muscular dystrophy, but not in others. We used the muscle biopsy features or muscle MRI more recently to really help categorize the patients. And obviously, as mentioned multiple times today already, genetic testing is really the gold standard. And I want to emphasize the fact that for any patient that we suspect to have LGMD, we really need to identify the genetic cause. That's really the diagnostic precision that's needed to the level of the gene. And as was mentioned again this morning, there's been many genes now identified. Some of them are listed here. There's more now that are not here, and the nomenclature needed to be revised. But the differential diagnosis of LGMD also includes other diseases like FSHD, as I mentioned. SMA is definitely in the differential, and also non-genetic muscle diseases such as myositis, specifically immune-mediated necrotizing myopathies. So to kind of put this in a picture, I'm going to use this paper that was published a few years ago from the MyoSeq project out of Newcastle. And in their cohort, like many other cohorts, when they do extensive genetic sequencing, they're able to identify about 50% of patients end up having a known genetic cause for their disease. And the take-home message here is that it's possible that some of those unresolved patients may have actually not genetic muscle disease and may have necrotizing myopathy. And I'm going to illustrate that with an example. So this is a patient that I saw when I was at the NIH now several years ago. He was 14. He was referred to us for evaluation of a limb-girdle muscular dystrophy. He had a 4-year history of slowly progressive proximal weakness, which resulted in him having difficulty participating in sports, and then later on, not being able to navigate stairs very well, getting up from the floor, had an elevated CK level of 8,000. It presented to the doctors locally, and they thought he had a limb-girdle muscular dystrophy, and they'd done genetic testing panel at the time. This included 121 genes, and they'd found a silent mutations in the DMD gene, which wasn't explaining the symptoms that they were observing. And so after all this evaluation, they referred him to the NIH for further genetic testing. And we thought this was really appropriate for the gene discovery program when we screened the case. So I'll show you a little bit of what he looked like. So he had proximal weakness. He had a little bit of calf atrophy. His CK level was elevated. And you can see the neuromuscular examination on the right side. He had quite a lot of it. So any number below 5 there means that it wasn't perfect strength. And the lower the number, the weaker the muscle group is. And he had quite a lot of weakness, especially in the proximal muscles. When we looked at his muscle MRI, he did have slight signs of fatty replacement in the hamstring group, but otherwise his muscle looked good, and he had a lot of edema on the muscle stir signal, as you can see there. I'll show you a quick video of how he was able to jump. So he was able to clear the floor, but it was very difficult for him. And he actually ended up, so he can actually clear the floor in that video. So we obtained his muscle biopsy slides that were done before and looked at him, and it looked very dystrophic with degenerating fibers, regenerating fibers, fibrosis. The dystrophin stain was completely normal, really ruling out that silent mutation that was identified as causative. And when we looked at this closely, there was two features that really stood out to us. One was the presence of MHC-positive fibers, which again is not diagnostic for inflammatory muscle disease, and it can be seen in dystrophies, but it was suggestive. And also he had a lot of regenerating fibers, which is less usual to see that in a muscular dystrophy, but it's more commonly seen in some of the inflammatory muscle diseases. So based on this, we went out and tested him for these two antibodies associated with necrotizing myopathy, and he tested positive for one of them. I didn't believe it when it came back as positive, so we wanted to do a confirmatory test, and we sent it for the gold standard test to one of our colleagues at NIAMS, at NIH, Dr. Mammon, who discovered this anti-HMDCR disease, and it came back positive there too. So we went ahead and treated him, and after about 3 months of immunotherapy, he got his strength back, his CK normalized, his muscle MRI normalized. He was back to playing sports, and he shared some of these videos of what he was able to do then. I don't know, the rest of the video is not playing, but for the sake of time, I'll just go through. So this really mimicked a limb-girdle muscular dystrophy in this child. So a little bit about inflammatory myopathies. I don't want to talk too much in detail. They also have their own classification system, which is undergoing changes. It was originally based on clinical features and myopathology, so muscle biopsy, but recently specific autoantibody testing has been more and more introduced in the classification system. And it's somewhat analogous to genetic testing. So, having the antibody really helps define these subgroups of patients. And this category of immune-mediated necrotizing myopathy is the group that can sometimes mimic muscular dystrophy, in part because the patients typically don't have a skin rash or any additional features like joint pain or lung disease, and their muscle biopsy typically doesn't have inflammation. So it has necrosis, it has regeneration, but those are findings that are common between that disease and muscular dystrophy. So that's why it can be potentially confused. Looking at the literature at the time, it was clear that some patients with this immune-mediated necrotizing myopathy presented with a chronic course of the disease and not acute or subacute, which is the typical presentation. So it sort of fit with what we were seeing in this child that was referred to us. So this made us think that how many other patients in our cohort have we missed? That we thought they had limb-girdle muscular dystrophy, we thought they had genetic disease, but they didn't. And so we went back to the NIH cohort. At the time, we had seen about 113 patients with undiagnosed hereditary myopathy or presumed hereditary myopathy. And we used a few clinical features based on our case and review of literature to select about 11 patients in total to test for this antibody. And when we did that, we had 6 positive hits for this, and the rest of the patients were negative. And of those 5 that were negative for the antibody, one of them ended up being diagnosed with Kaplanopathy with a difficult to find mutation in the second allele. And then another patient had negative testing had positive testing for GMPPB, which was originally not covered on the panel that they had at the time. And 3 of them remain undiagnosed to this day. So we went ahead and also treated the rest. So that 6 includes the patient that I presented, so 5 additional patients. And really, when you look at the data again on some of these patients, they really mimicked limb-girdle muscular dystrophy. So on the left, you see a patient with Kaplanopathy with the scapular winging and the MRI pattern. And on the right, this is one of our HMDCR patients in this new group, who also had scapular winging, and his muscle MRI was really resembling Kaplanopathy in the pattern of distribution. So this was clearly a mimic. We then reached out to our colleagues in France who have a large cohort of anti-HMBCR patients, and they also noted that in their cohort, about a third of patients had a very chronic and prolonged presentation, and the details are sort of listed in that table. And over the years, there's been several case reports of anti-HMBCR disease mimicking a chronic limb-girdle type muscle disease that have been reported now. So in conclusion, I think that anti-HMBCR necrotizing myopathy can mimic limb-girdle muscular dystrophy. Some of the patients have a very prolonged asymptomatic phase, prolonged hypercikemia before they develop weakness with this disease. It's a slowly progressive course over decades for some. It has a propensity to affect the posterior and medial thigh compartment, as seen on the MRI. If you treat the patients early enough, they do have a favorable response to immunotherapy. IVIG is what we use, but other immunotherapies as well. And I didn't talk about this, but these patients do have a genetic risk factor for autoimmune disease in HLA-DRB1, which is really not the same as a Mendelian type of disease that we would think about. So these patients have a propensity to develop autoimmune disease and not necessarily genetic muscle disease. So what's the impact on my clinical practice is that, I think that all of the testing that we do in isolation are insufficient, and I have incorporated testing for anti-HMGCR myopathy early on in the diagnostic evaluation of the patients with suspected LGMD. And I would include anti-SRP as well because it's another necrotizing myopathy. So with that, I would like to end and acknowledge everybody at the NIH and give it to the next speaker. Thank you.
Thank you very much for a great presentation. So our next talk is going to be done by Dr. Chris Weihl. He's a neurologist and professor of neurology and head of the neuromuscular section at Washington University School of Medicine in St. Louis, Missouri. Dr. Weihl?
Great. Thanks, Laura. Great. It's a pleasure to be here. I hope Catherine's watching, so I would just want to say thank you to Catherine Bryant. I'm sorry she's not here, but she's been great at kind of organizing this meeting. I wanted to talk about genetic testing, but before I talk, I want to point out just one aspect of genetic testing that I don't think we always think about, and that is that the reference genomes, so the references that we use in genetic databases, are predominantly Western European, Caucasian individuals, and so that leads to some inequity in whenever we interpret genetic test results. And we're getting better about it, we're acknowledging it, but there are efforts at the NIH to create increasing genetic databases for those of marginalized communities, traditionally in healthcare. And so I just want to always kind of point that out. The goal of my talk is really to talk about types of genetic testing, barriers to genetic testing, understanding really genetic variation, and then interpretation of genetic test results. And so the genetic testing that we do in clinical practice, you'll see us, sometimes we'll do individual gene testing. That's usually whenever I know somebody in the family has a hereditary disease and I'm looking and I actually know what the mutation is. This, of course, doesn't acknowledge and sequence the other genes that might be associated with a limb-girdle muscular dystrophy phenotype. And the way to do that is by panel-based sequencing. And that usually looks at all the likely LGMD genes or myopathies. One thing that's important whenever you're a patient and you're going back to your clinician is that these panels have evolved over time, and older genetic panels actually don't have newer, have missing genes. And so it's important actually, if someone says, oh, I've had genetic testing, it's important for the clinician to say, well, where did you have it done? What was on the panel? Especially if you don't have a diagnosis. And then whole exome sequencing, this is an approach where it sequences every known coding gene in the human genome, and it's won't miss genes, but it is imperfect, and it's not a perfect solution. And so I say this mainly if you've had genetic testing, you're still struggling with the diagnosis. And then finally, whole genome sequencing, and those can be, those are newer approaches and are approaches that sequence the entire genome. And so I always want to bring up kind of the barriers to genetic testing. Some of them are getting better, but often payers are not willing to pay. There's free genetic testing programs that are out there that have really helped with that barrier. Patient knowledge, saying, oh, I've already had genetic testing, but not realizing that maybe they need to get updated genetic testing. Community knowledge, this is a great example of where the community can help educate others in the community about the importance of getting a genetic diagnosis, not just limb-girdle muscular dystrophy, but actually your subtype and your genetic diagnosis. I would blame physicians. We often don't realize that we need to do that. And then I put down patient care guidelines because this is actually the most current patient care guidelines as far as evidence-based guidelines from the American Academy of Neurology of 2014, so it is dated, and it is being updated, but at that point, it was level B evidence, which means that it was kind of consensus guidelines that you should really just do single gene testing based on the patient's phenotype. We know that that is not the way we would do that. Level C evidence, which is just expert opinion, so this is my opinion, is that you should have panel-based sequencing or exome. So this needs to change. And I would give credit to the MDA and the Jane Foundation for really helping breaking down some of those test barriers. And so there was a comprehensive genetic testing program that offered point-of-care genetic testing. And I bring up point-of-care genetic testing because being able to see a patient in clinic and get their genetic testing done in clinic is far different from seeing the patient in clinic, sending them home, hoping they follow up, contacting insurance, sending them something in the mail or whatever it is. And so by doing this, we were able to sequence about 3,000 patients with limb-girdle muscular dystrophy. And this is a really important figure that they are able to show, which is that they're able to show the prevalence of a whole variety of limb-girdle muscular dystrophies. But actually, the data also really shows that they only solved or actually diagnosed about 3% of patients, and that negative genetic testing was in a quarter of them, and about half the patients had unresolved variants of unknown significance. And so what is a variant of unknown significance? So this is an example of a genetic test report from patients that we have in clinic. It's a patient with slowly progressive weakness of a limb-girdle muscle phenotype, and you can see that they have several genes that say uncertain significance. And really, that's a non-answer for the clinician. It's a non-answer for the patient. And so I want to, before we understand the idea of what a variant of unknown significance is, I want to kind of step back and really understand human genetics for just a second. And so it was really, when I think of the start of genetics in my life, it was really beginning with the Human Genome Project, which was a $3 billion investment that was led by Craig Venter and private industry, and then Francis Collins at the NIH. And they spent $3 billion and they sequenced one person's genome. We now know today that we can do that for under $1,000. But this was hugely important, and it was this paper that then really, so now several years later, and actually still very recent, only 10 years ago, that we really were able to sequence 1,000 patients' genomes and really understand the amount of variation. And what did this actually show? So this actually showed what we call low-frequency genetic variation or rare variants. And actually, if a single individual, you can see we all have many common variants, but there's a subset that has very rare. So we all have about 30 to 40,000 rare variants, and some of those are unique to an individual person, or they might be unique to their family lineage in some way. Of those, 250 to 300 are actually loss of function, meaning that the gene presumably shouldn't work at all. And in some cases, it's on both genes. So we're all knockouts of a certain amount of different genes. And I bring this up because now I get a genetic test report and I've got to interpret it knowing that many people have loss of function variants in genes. Of these, 50 to 100 are in genes that are implicated in hereditary disorders, and 0 to 7 are actually known pathogenic variants. So we all have variants of unknown significance in our genome. And so if we go back and look at this, I can look at that top one there, and I can see that it actually takes that protein and it terminates it. And so the geneticist can look and be like, well, that's not going to make that protein, and they can say it's likely pathogenic. But the other ones make small changes that are hard to interpret. And the way I think about it is kind of going back to our high school, and actually now it's probably elementary school, where we teach the kind of dogma of DNA to protein. But you have DNA that goes to RNA, that goes to protein, and it's like I said, how we would think about it, a cookbook, making recipes, which are the RNA, and then making whatever the recipe is telling you to make, a cake. But sometimes there can be a problem, and you can get a variation, okay, in the cake. And the challenge is, what we're asking geneticists to do is to take this recipe, and so I want you to think of this as a recipe, or I want you to think of this as amino acids in a protein. And what we're tasked to do is to interpret what would happen if half of the protein or half of the recipe was absent. And you and I all can look at that and be like, they're not getting a cake from that. That's not going to happen. And I can say they're not going to get a protein. But what about this case where they do what I often do, which is I forget to preheat the oven? I actually know from experience, I know from lots of different times I've made a cake, that I'm still going to get a cake. I didn't preheat it, that's okay. So that would be a benign variant. I'd be able to look at that and say, that's a benign variant. But what about something like this, where if I leave out the baking soda, or the one I love is this teaspoon of salt I always seem to have to add to a cake that I don't even know why I have to do it. I actually don't know if I'm going to get a cake. I don't have enough experience to do that, so I don't actually know. And so those would be variants of unknown significance. And so now if we go back and look at those genetic test reports, we can kind of understand why they have these variants of unknown significance, because they're asked to predict, based on this patient's DNA or protein, whether that would cause a variation that would be detrimental to that protein. And so the challenge of variants of unknown significance are they leave patient with diagnostic uncertainty, family planning issues, physicians with diagnostic uncertainty, not asking you to empathize with us, but we want to help understand what's going on as well. They can lead to inappropriate treatment and testing, increasing healthcare costs, and also a poor understanding of the true prevalence. So it's really something that we need to understand. And finally, ultimately, perhaps missing out on gene-specific therapies. And so I think this is really something that's important. If we look at kind of genetic test results, so this is that same example. This is a patient with progressive weakness. So are these pathogenic or are these incidental? And I just put up a whole bunch of different ones, because you can see, my point is that all of us, not just patients with limb-girdle muscular dystrophy, but all of us have variants of unknown significance in these genes. And so the way that we clinically would approach this is we're moving into an era where we're often doing gene-first approaches, where somebody comes in and they get genetic testing done first. And in some cases, I've had patients show up with a genetic test report. They haven't even seen a physician yet. They already have their genetic test result. And so we're being asked to kind of understand that. And so I would say the ease and low cost of genetic testing has allowed them to receive genetic testing, sometimes without clinical assessment by a neuromuscular physician. They may have seen a neurologist, but not from a neuromuscular. And then I would also say that lack of experience with genetic testing leads many neuromuscular physicians unable to appropriately order and interpret. And so the issue is that we really need to be working together. Geneticists and clinicians need to be working together. And the question would be, do you examine the patient first, or do you order the gene test first? And so this is an example of a patient that came to me with a genetic test result. It's a mutation in DNA JB6. DNA JB6 causes an autosomal dominant, so you just need one mutation of limb-girdle muscular dystrophy. And really, this was a slam dunk. They'd already diagnosed the patient. But this is another example of a patient that came to me with a genetic test report telling me they had limb-girdle muscular dystrophy, and they had a variant of unknown significance. And so this is really, the patient needed to be examined. The patient didn't have limb-girdle muscular dystrophy. The father actually had the same variant. He didn't have any evidence of limb-girdle muscular dystrophy. So really, we need to be working together. And so I put these up because I just think it's important that all of you know that genetic test reports are confusing, and your genetic test report may be confusing, not because you've got two different diseases, not because you're some anomaly out there. All of us have all of these different variants. And so I want to give you an example of what we would do clinically. So this is a patient with calpain-3, 2 variants. One says pathogenic, one is a variant of unknown significance. In calpain-3, which is limb-girdle 2A, you have to have 2 mutations. They also have a dysferlin variant. That's a variant of unknown significance. And so this is a 34-year-old man with limb-girdle muscular dystrophy, and this is what the panel demonstrated. And so what the clinician needs to do, and this is why someone can take their genetics reports and really needs to be seen by an expert clinician, a neuromuscular physician, we would then integrate a bunch of clinical data. So what's their age of onset? What was their first symptoms? Do they have a family history? What's their pattern of weakness? And so in this case, the weakness began at age 25. He had difficulty climbing steps, so proximal onset. There's no family history. He's got proximal weakness on exam. He has a feature that Payam just explained of scapular winging, which can help be distinctive in certain muscular dystrophies. We do other tests. We integrate lab data, so the muscle enzyme, the electrodiagnostics, if they had an MRI of their muscle or muscle biopsy. And so this patient had a CK that was elevated, so that's helpful. He didn't have an MRI done of his muscle. He had normal cardiac issues. He had a muscle biopsy, which shows evidence of a muscular dystrophy, so that's helpful. So often I'll get patients that will send me their genetic test result, and they won't have any workup done at all, and I'll even ask, are you weak? And they're like, well, I have cramps, and so it's hard to know unless we are able to examine these patients. You can do database searches and look for functional predictions. So in this case, that calpain-3 variant is unreported, so it's unique to that patient. It ends up being, if we put it into different programs, we can see that it causes a splice variant. That's something that we wouldn't typically always look at. And the other important thing is to look at that other variant and that other gene and say that that dysferlin variant actually is fairly common. It's rare, but it's common enough that we wouldn't think that it would be causative in this disease. And then we do other things. I might say, well, we need to see if this thing actually segregates in the family. So we sent out and said, can we get genetic testing done on your mom and your siblings? And so we did that, and you can see that the patient's siblings were unaffected. And so if they were unaffected and they had both those variants, you'd be like, well, I'm not sure if that's causative. And then they did other testing as well. So we were able to actually look and actually show that they had a reduction of dysferlin, but that could point to dysferlin, but we also did more testing and actually showed that that protein calpain-3 is absent in this patient. And so that leads to resolution of that variant, which I would say it was quite cumbersome, took a specialist. It requires specialty testing and a lot of work. And I would say it's actually become more complicated because some of these limb-girdle genes are now also behave in recessive dominant, and we're actually learning that some limb-girdles can behave both ways, dominant and recessive. So it becomes very, very, very complicated. And so how do we solve this issue? How do we get ahead of the game? And so we've been working with ClinGen to do systematic variant resolution, and this has been a partnership with the NIH. We've actually been partnering also with the Jane Foundation as well as Cure Calpain to create curation panels. And really, the questions are really important. The first question is, does the gene actually cause a muscular dystrophy? So that's question number one. The second one, which is the one that we're most interested in, is does the mutation or the variant in that gene, is it actually pathogenic? And the third is one that I think hopefully we'll get to someday, which is that gene amenable to some type of therapy and clinically actionable? And a clinically actionable gene is something like BRCA1. So if you have that as positive, that's clinically actionable, meaning that you need to get screening done for breast cancer or whatever it is. And so wouldn't it be great someday if you got a genetic test report that said, and you've got this mutation, it's pathogenic, and you're amenable to this treatment? And that's where the world hopefully will go in the next few decades. How do we do this? We do exactly what I did in clinic. So we integrate lots of different data, and we kind of combine different information. We kind of stack it all together. How rare is it in the population? Does it segregate with the family? Is there functional data that we've done in vitro, meaning in a cell line that can help us understand it? And we kind of stack it together. And I would say at this point, we have an incomplete library of the functional consequences of these genetic variants, and we need to move to a place where we have a complete library or database so that whenever somebody has a genetic test report, they can look in that database and say, yes, that's been already adjudicated as pathogenic. And so oh, doesn't have my new slide deck. Oh, well. So we've been working. So we've been working on doing systemic variant resolution, where we've actually been able to actually do this in vitro and actually make every single point mutation in a protein and actually create the recipe for that protein and see if it's actually made and see if it's actually functional. And so that's the future goal in some ways. And then we've been able to take that and actually screen different drugs onto that as well. So hopefully we not only identify that the patient actually has the mutation is pathogenic, but we might be able to do a personalized small molecule screen and actually identify whether that patient would be amenable. So at present, genetic testing really requires what I call kind of armchair, which is, me sitting back in clinic and, espousing how I think it could be pathogenic, versus a systematic way, which is what we're really trying to do. And that in many cases, it requires enhanced clinical phenotyping by an LGMD expert to really make that diagnosis. This is my group, and I want to thank many of the GRASP consortium members as well. So thank you.
Thank you, Dr. Weihl. So our last talk of this session is going to be given by Dr. Volker Straub. He's a neurologist and professor of medicine and neuromuscular genetics and the director of the John Walton Muscular Dystrophy Research Center at Newcastle University in Newcastle in the UK. He will be just talking about developing standards of care for LGMDs. Dr. Straub?
Thank you very much, Laura, and thank you very much actually to the LGMD community for kindly inviting me to the conference, particularly to Catherine Bryan Knudsen and also to Brett Williams. Really appreciate it to be here and talk about one of my favorite topics, limb-girdle muscular dystrophy. So you've heard about Newcastle upon Tyne a few times, that it's in the northeast of England, and why Newcastle really? Because this is where the term limb-girdle muscular dystrophy was first time proposed by John Walton, and we are the national referral center in the UK actually for patients with limb-girdle muscular dystrophy. It's more known for football, what we call football, because it's played with a foot and it's using a ball, what you call soccer. Actually, there's kickoff in about an hour. Now, my disclosure statements, I think often people skip through these disclosures far too quickly. This shows that I'm working with industry, and I think it's really important that there is actually a stakeholder collaboration, both with patient advocacy and with industry. For this talk, there is no conflict of interest, I think. Another disclosure is that I'm not going to tell you anything new. Apologies for that. I'm mainly going to actually summarize what people have already told you. So the objective is to tell you a bit about developing standards of care for patients with limb-girdle muscular dystrophy. And so you should get an idea after my talk to understand the importance of standards of care, why we need actually disease-specific aspects of standards of care, and that there is a dynamic nature when standards of care apply. Now, my challenge is, this is the third talk in a row. I don't want to lose your attention. I need to make sure that you're not falling asleep. So I think one clear message that you have heard already is that limb-girdle muscular dystrophies are very heterogeneous. And it was lovely to talk to some of you yesterday evening already at the reception. And I just realized that there are many people with very different diseases in the audience. And it's a bit frustrating that we talk about limb-girdle muscular dystrophy and think, well, which limb-girdle muscular dystrophy are they talking about? And how does it apply to me? Now, there are two things that apply to all of the limb-girdle muscular dystrophy. First of all, the skeletal muscle is involved in all of them. And some of them, the heart is involved, and some of them, even the brain can be involved. But the most important thing is that all of these diseases are ultra rare. Okay, this is why we are here, because they are ultra rare, and that's why we still have fairly little knowledge about them. Now, standards of care is important because patients and their family should be offered the best informed treatment, management, and counseling, regardless of where they live. Okay, normally, as a patient, you go to a doctor with a problem, and you expect that the doctor tells you, this is what you have, and this is what you do about this. This is the concept of medicine, very basic. See, with your diseases, that's not the answer that you get. Most of you will have had a journey of years before the doctor understood or told you what you actually got. And often it's about, well, maybe you're just lazy, or wait, it will get better. And even once the diagnosis was provided, there was no one often who told you, and this is what we are going to do. And you're coming to this conference because ideally, now you have the experts here, the world experts, and you hope that they can tell you this is what you have to do. Now, the problem is you have heard earlier today, well, you are the experts. And you think, that's quite a responsibility and burden. Because the problem is that even the experts sometimes don't know what to do, okay? And now that's very frustrating, and you think, well, how is that possible? Because you're paid for this, you have a job, you're working on limb-girdle muscular dystrophy. Well, because, and Chris Weihl mentioned this as well, that yes, we are the experts, but sometimes it's our opinion, this is what you should do. And Chris briefly mentioned breast cancer. And you can see with breast cancer, for example, if you go to a doctor and one doctor says, oh, we have to do a complete mastectomy, removal of your breasts by surgery. And another doctor says, oh, no, we don't have to do this. It's fine to actually, we don't need any surgery, you just take this drug. You think, that's a problem if care standards are based on opinion. Ideally, you want to know, well, what is the evidence that I need surgery if I have a, BRCA mutation, or can I just use a drug? So for limb-girdle muscular dystrophies, because these are ultra-rare diseases, that's the problem. There's very little experience, and maybe the guys or the experts that have experience have different views about this. Well, take botulinus toxin if you have contractures, and in other words, oh, never do this because it damages the muscle. What is correct? Now, we have some existing templates, how you develop standards of care. And the big challenge is, do we have evidence to advise you what to do when you have a diagnosis? Or is this just because, an expert thinks, well, this is what I think is best. So we need to collect evidence. And this is coming back to what you've heard this morning about how do we collect evidence. Okay, so, and there are various ways, and it depends on how robust it is and how much you invest. So you can just actually collect, for example, data through patient registries, where patients often say, well, this is what I've experienced. Or you can go through a natural history study that you have heard about this from Meredith and from Linda. Or, the most robustness is through a clinical trial where everything needs to be monitored for very good reasons. And so we collect this evidence ideally with good robustness. And if it's not an intervention, and unfortunately, for none of the limb-girdle muscular dystrophies, there's currently an approved treatment for a specific indication. So, this is the bad news to all of you. The good news is we're working on it, and it, looks really exciting, I think. So why is the natural history important? And I think that the top line is what you take away. Key to management and advice for you at a specific point of time, okay? It's also important to understand the longitudinal, the cause of the disease, and of course, to use this as comparative data for clinical trials, and to know whether we use the right assessments. And you have heard that there are now a number of natural history studies that are trying to collect evidence. And I'll just briefly mention again the clinical outcome study in dysphalanopathy, because this is currently the biggest natural history study in limb-girdle muscular dystrophy. And Meredith James mentioned that we are collecting many things across many sites, and we have done this in 200 patients over many years. So we have a lot of data that we have collected for this specific form of limb-girdle muscular dystrophy. And Chris also pointed out that we need to make sure that we are not just looking at one specific ethnic group, but we have to think about ethnic diversity, and maybe limb-girdle muscular dystrophy manifests differently in Asian populations or African populations, because our approach is holistic, global. And we need to work globally because otherwise we don't have enough patients, because these are ultra-rare diseases. So in the cost study, we have then said, okay, based on our evidence, let's see whether we can come up with recommendations so that we can inform patients, this is what we advise you to do or how we manage your disease so that you have the best outcome possible. And we did this also in collaboration with the European Neuromuscular Center, which facilitates workshops. Many of the clinical experts, probably all of them, that are in this room have been involved in this process as well. And we looked at different topics that we felt are really important. On the one hand, genetics and diagnosis, and Chris Weihl just gave a fantastic overview about why this is so important. Then motor function and exercise, and again, you have heard this morning why this is so important. Then, because it's muscle and the heart is a muscle, we needed to look into the involvement of the heart as well, and the breathing, because breathing is really important. The heart and the breathing is what needs to keep going. If that stops, we have a problem. And then there are questions about, are there other organ systems that are involved? For example, immunology. So we have just heard that autoimmune diseases can also cause limb-girdle muscular dystrophy. What about pregnancy? What about diet? I mean, these are questions that often patients actually have. Can I do anything about this? And so just to give you an idea how we did this then, and this is specifically for dysphalanopathy. And so this graph has actually been generated by two of the people that are sitting on the panel here, Laura and Chris. How do we make sure that the diagnosis is correct? And again, after talking to some of you yesterday, it's interesting that, not everyone with a form of limb-girdle muscular dystrophy is always certain that, do I really have this diagnosis? I'm not sure. My clinician wasn't even quite certain because, I have this variant of unknown significance in this gene. So for dysferlin at least, and for most of the limb-girdle muscular dystrophies, because they are recessive, if you have two genetic changes in your copies, one comes from mom and one comes from dad, and they have been shown to be abnormal before, then you can make this diagnosis. But sometimes you may need a muscle biopsy, and you may need an MRI, and you may need additional blood tests, and it's a lot more complicated. And again, coming back to what Chris Weihl just said, even for the geeks, the experts, it's not always certain that we can make this diagnosis. Extremely frustrating for those patients who then are affected by this. Now, you're not supposed to read this, even though it's the most important slide of my talk. It just shows that, okay, we have looked at other aspects of management. And again, to all of you who are affected and the family members, you can probably relate to many of these topics. What about exercise? What about splints? Do I need them? What about pain management? No one is talking about pain, even though that is actually my main problem. breathing, should I have my heart tested or not? Do I need a specific diet? Can I change anything? Can I improve the disease course through a diet? What about bone health if you have had a fracture? Pregnancy, is it okay to actually have children if I have limb-girdle muscular dystrophy? If I have to go undergo general anesthesia, is that possible? Is there a higher risk? What about vaccinations? COVID, it was a big question. Is that okay for me? What about my psychosocial well-being? Who's looking after that? And so we have tried to address all of this based on experts. And what's really important is that the experts were also patient voices. It's not just the clinicians. And then, of course, for almost any limb-girdle muscular dystrophy, there is a disease course when you're more abled, and then, when you're non-ambulant and wheelchair-bound. And so the advice depends also on the stage of your disease. And I said there's no approved treatment yet for any of the limb-girdle muscular dystrophies. But this is a slide that you should also take with some, and look at with some encouragement. When I started 30 years ago, I was very young, there was no drugs at all. And now I can go to conferences and say, well, these are drugs for patients with muscular dystrophies or spinal muscular atrophy, with genetic diseases. And just actually last week or this week, FDA also approved vamorolone, another drug which isn't even on there because I had to submit my slides early. So there's more coming. It's really fantastic. And of course, once you have a drug, that changes your care recommendations, your care standards. For now, and we have heard this morning from Meredith and Linda, there are still direct care implications, many of which are symptomatic. The physiotherapist, avoiding joint contractures, so stiffness of your joints, splinting, orthotics, occupational therapies. I see many of you here with wheelchairs. See, as a clinician, I think that's a fantastic treatment because it gives you mobility and independence. But of course, if I give the diagnosis of limb-girdle, it's this elephant in the room. It's like the wheelchair is a stigma. It's something, terrible. It tells me something about this disease is getting worse and I'm getting less functional. But you could also see it as a treatment, definitely as a care standard. So, even looking at a bathroom and refurbishment, you could say that's part of a care standard. Ideally, if you can't, take a step, then, you should have a shower without a step or a bathroom. So it's a long journey, and many of you have been on this journey and are at different places of these trajectories. But because it's limb-girdle, unfortunately, currently it's always going downhill. But it's again important for you to plan, and I think we heard this, or you heard this morning as well. Planning ahead. If you want to. If you're 20 and you have just been diagnosed, but you're still very mobile, do you really want to invest in a flat with stairs, or do you want to have a bungalow? It's important that people tell you a bit about when can I expect that I am, for example, losing certain milestones. So this is what, therefore, standards of care need to take into account as well, that there is a, there's a change, what you need. And of course, often kids are diagnosed as well, and care for kids is actually quite good in many countries, particularly in the UK. But once you are an adult, and the adult services are often a lot worse in terms of what they offer. So you have to plan for this as well. So care recommendations change with the disease and with the stage of the disease. And when I say with the disease, there are some limb-girdle muscular dystrophies. We haven't discussed this yet in detail, but I think there will be more talks. Care for the heart involvement is the most important. And for others, we can tell you, you don't need to have your heart checked, not for the limb-girdle muscular dystrophy at least, because there's no evidence that it will ever affect the heart. And this is just an example from Northern Ireland, that care standards, of course, also depends on where you live. And I think many of you will have experienced this. Where you live, maybe there is no expert center, and your general practitioner has never heard about limb-girdle muscular dystrophy, and you need to educate the healthcare professionals. So this graph in Northern Ireland was just looking at getting counseling in your GP practice. So there's some areas where every GP practice does this, and in others, it's very low. So the health system, of course, is very different. I mean, in the US, it's very much insurance-based. What are you covered by? So you can't just get everything because actually you can't afford it, or the insurance doesn't provide it. So it has financial implications. But even acceptance among healthcare professionals. So even though, if the experts recommend something, another healthcare professional might say, oh, what do they know? So it can be difficult. So therefore, it's important to have something ideally in your hand. But as I said, we also need to make sure that care standards can be globally applied. And if you would say, well, genetic testing, but in many countries of the world, genetic testing isn't even an option. So we're also looking at how can we, for example, if we look at respiratory function, in some African countries, you can't look at respiratory function, but can we correlate this with arm function? And for dysferlin, we have now done this, and I think it's really excellent, but this only applies to dysferlin, not to other diseases. You have to do this for each limb-girdle muscular dystrophy. So we have started with dysferlinopathy, and Laura, we will publish this. It's currently still with me. We are also then wanting to extend this to other limb-girdle muscular dystrophies, and we have planned an LGMD R9 European Patient Day, where we also want to hold a standard of care workshop. The take-home message for you is make sure you have a precise diagnosis, and if you aren't certain about it, make sure that there is some certainty. Is a precise diagnosis necessary? Hopefully, I've already explained yes to receive the best care for your disease. But of course, it has more implications for genetic counseling. And the precise diagnosis is also important. If you want to participate in clinical research, in a clinical trial, you need to have a precise diagnosis. If you want to get future therapies, you need to have a precise diagnosis. Okay. So these were my objectives. You hopefully got an idea why it is important to have standards of care, and that this depends on the specific form of limb-girdle muscular dystrophy, and this changes the management over the course of the disease. Looking around, looks okay. So I want to express my gratitude to the Jane Foundation, in particular to Laura Ruffibach and her team, as well, the people working with her, with Doug and Sarah, who are here. The Jane Foundation has been amazingly generous to invest into building the foundation for clinical trials. We don't often see this industry is not necessarily very keen. Often even government funding is difficult for natural history, for collecting evidence to establish care standards and to do clinical trials. So thank you very much for this to the Jane Foundation. And thank you very much for your attention. And this is our team in Newcastle. Thank you.